Hello, and welcome to the webinar, Laying the Groundwork for Meeting QI QA Program Expectations in an HCH Setting, Lessons Learned from the San Francisco Healthcare for the Homeless Program. A production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration. My name is Julie Hashida, and I will be acting as moderator for today's webinar with tech support from Patrina Twilley. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. A selected number of questions will be answered at the end of the presentation during the Q&A session. Now I would like to introduce you to the presenter, Amy Petersen. From 2007 to 2011, Amy managed the Quality Improvement Program of the San Francisco Community Clinic Consortium, which is a partnership of 10 community clinics and health centers. SFCCC administers a federal HCH grant and contracts with city partners for the provision of HCH services serving more than 15,000 homeless individuals annually. Amy recently joined the San Francisco Department of Public Health Community-Oriented Primary Care team, where in an effort to meet the challenges and opportunities of significant healthcare reform, she coaches and supports 14 primary care clinics in data-driven quality improvement activities. Amy Petersen received the best training from everyday people in San Francisco while working as a community organizer. In 2005, Amy earned her master's degree in public health from the University of Michigan, Ann Arbor. She completed the Health Research Education and Training Program with the New York City Department of Health and Mental Hygiene Continuous Quality Improvement Bureau and interned with the New York City Mayor's Office of Health Policy to coordinate a citywide platform for addressing health literacy. She is a graduate of the Urban Studies program in Chicago, Illinois, completed the Institute for Healthcare Improvement Breakthrough Series training, and is an alumnus of the Blue Shield of California Foundation Clinic Leadership Institute. She was recently accepted into the Kaiser Improvement Institute program. And now for your presenter, Amy Petersen. Amy?
Hi, Julie. Thank you for the introduction. My humble thank you to the HCH program and many of the people who have been doing this work much longer than I have and maybe in a more meaningful way than I have. I've learned so much from our community advisory panel members and HCH care teams throughout California and the rest of the country. So Patrina and Julie and I will be communicating a little bit throughout the presentation to make this somewhat interactive. I am going to be briefly talking through the core program requirements. The core program requirements from HRSA for QI and QA programs. We'll talk through those requirements, and then I will present just 3 case studies of how those program requirements are met in different settings. So let's just look at the learning objectives to make sure that we're all familiar with what we should be achieving today. So here are the 3 program requirements. Everybody likely knows where to find these Reqs, but here are just a couple screenshots from the HRSA website. For a while, I literally kept this page bookmarked on my phone and at my computer at work. Maybe some of you can relate. There's a sense of frustration that can come out of the vagueness of these program requirements. And you may be able to shift into an area where you accept the vagueness and change your perspective to think that maybe there's some degree of ability in these program requirements to give you the scope that you may want to embrace with enhancing and growing your QI program, because these program requirements can be looked at in very interesting ways, and we'll get into that with the case studies. So just to make the business case, which is one of our learning objectives, here are one of the standards for the National Committee for Quality Assurance Patient-Centered Medical Home Program, which many people are probably familiar with. Standard 6 is around QI, and we see the 4 bullets below outlining the elements that you have to meet to score points on this standard. It's one of the core standards. And I want to bring your attention to the second and third bullet, which are about looking at utilization measures like ER visits and hospitalizations, and more importantly, identifying vulnerable populations. These activities meet patient-centered medical home requirements, but also get some of the investigation and response to health disparities experienced by your patients who are homeless going at your clinic. So thinking about ways to incorporate, if you're not already doing this kind of work, if there's someone in your health center or management team that's saying, you know, we don't need to look at health disparities for our homeless population, or we don't really need to look at ER and hospitalization visits, you can bring them back and redirect attention to these core program requirements. And if this is something that you've been doing, you definitely want to continue doing it for the purpose of looking further down the line at PCMH recognition, which will likely be attached to payment reform. So I'm going to go through the core requirements and then give you some case studies of what happens here in San Francisco. I'll cover 3 different healthcare environments. And I want to make reference to a very valuable resource that we have here in San Francisco, who is Dr. Barbara Wismer. She's been practicing in San Francisco Safety Net for the last 12 years, and she's also been the chair of the HCH Practice-Based Research Network, is a member of the Research Coordinating and Communications Committee, and she will be presenting along with Dr. Deb Bourne, who some of you know, at the 2012 conference coming up in May. And we're going to highlight some of the work that they're doing at the end of this presentation with a case study for the health center she works at. But if anyone's attending the conference, her presentation is on Wednesday the 16th at 10:30, and it's about enhancing quality outcomes using QI tools. All right, so this is just where I am. I'm with the San Francisco Department of Public Health. We have about 7,500 homeless patients that we see across our network of primary care health centers. From 2011 to 2012, our top diagnoses for homeless patients were hypertension, diabetes, HIV, depression, obesity, and pain. And I'm just sharing that to make reference to probably some of the overlap that we have across the country with San Francisco and your own health center environments. All right, so let's just jump into the first program requirement for HRSA. This is having a QI plan or a QA plan. Everybody probably has one somewhere. If you're new to your health center or health center organization, you're responsible for putting this plan together. Ask around people who've been there for a while about if there's been one that has existed before. I've never found a health center that doesn't have one. Most organizations just haven't dusted it off in quite some time. It should really take no more than a couple days to draft up a QI plan. You can see there's a screenshot of, if you just Google QI plan, you'll get lots of resources. Personally, I'm a fan of the National Quality Center. The focus of NQC is HIV, but they have tons of resources on their websites, templates for quality management planning, as well as slide decks that can lead your quality improvement committee, if you already have one, through the process of putting a plan together. If you don't have a QI committee, you don't need to wait to have one in order to put a plan together. Use any existing committee, your management team, any work group, a larger local structure that you have around quality improvement. Use past data reporting goals and initiatives that you might be involved with to inform your QI plan. Let's move on to the next requirement, focused responsibility for a QI program. So what is the purpose of a quality management program? Here's 4 bullets to think about when you are working to identify who will be leading up your QI efforts. This is really what you want your QI committee leader, your QI director, whatever title they have, to do. You could think about putting some of these bullets into a job description and really consider how this person will be interfacing with your management team. This is a valuable lesson that I've seen in many settings where there can be a disconnect between the work that the QI committee is doing and the person who is leading that work and the priorities and strategic planning efforts that are happening among the management team. You really want to align those 2 activities and think thoughtfully about your membership and role assignment for the QI work in your health center or health center organization. 3 other questions to ask when you're thinking about people and focused responsibility is who's going to do it, how often will your work group meet, and what kind of ongoing training can you provide? You think about these questions differently if you're in a large network with multiple sites as opposed to a single site. But either way, remember your QI plan should be laying this out for you. It should tell you, who's responsible, what your committee membership is, and how often they meet and how you provide training. Those are core components of any kind of QI or QA plan, and if you're not familiar with them, you'll see them in any of the templates that you start to look at. Another useful piece of advice for meeting this core requirement is to survey your environment on a regular basis. There's lots of survey tools, again, National Quality Center, and we'll show the web link for the National Quality Center at the end of this presentation. They have a couple assessments that you can do that help you look at the knowledge, skills, and ability of staff or members of your QI committee, and you can find the gaps in the knowledge, skills, and ability related to carrying out QI work, and that will inform your ongoing training plan in your clinic or health center environment. So here's another way to think about the leader. This is really, really important, that you have the right person who is motivating others in QI work groups and connecting the QI work that's going on in your environment to some of the larger QI initiatives that are happening in your larger healthcare setting, whether it be your hospital, your health plan, your primary care association. But there's specific tasks a leader should be able to do, and I'm just going to highlight a couple. One is to help overcome inertia. We're all inundated with lots of requirements, whether it be for grants, contracts, or local initiatives. And this QI leader really needs to have a healthy dose of optimism as part of their personality. They're really helping keep people stay motivated. They're doing a lot of the messaging in your health center or your health center organization. They're encouraging experimentation. And they're helping bring the right people onto your teams or your work groups to do and carry out different QI initiatives. Think about somebody who might be natural at coaching or who's naturally interested in transferring skills out to other members of your care teams and your staff. Next, by being involved in all areas of improvement, this leader has to be able to make more informed decisions and also see the larger context of what's going on outside of your health center. So they need to be able to blend the efforts that are happening inside your health center around quality work into the efforts that are happening outside your health center. This will make the work that your health center decides to take on much more efficient. Instead of looking at 10 different measures of quality, this person will help you identify the top 3 that are aligned with your priorities inside the organization and outside the organization. So take some time if you're involved in appointing the member or the director of your QI program, or if you are the QI program director, take some time to think about how you work outside your own health center. Are you connected to local QI planning efforts? Are you active in your state primary care association? Are you partnered with your health plan or your local hospital's QI structure? So our next core program requirement is doing periodic assessments. Some things to think about. What are you reporting now in terms of requirements? How accessible are your data, which is sort of a conundrum for all of us if anyone is involved in EMR implementation. What kind of goals you can set and how frequently you can report. If anyone is in the middle of EMR implementation, it's important right now to consider any kind of workflows that you have specific to healthcare for homeless care provision and templates that you're going to want to create and structured data elements that you're going to need in your EHR to be able to report on your quality measures. In San Francisco, we are really lucky to have a health plan medical director and a health improvement director who've worked alongside our health center providers and our safety net leadership members to develop a pay-for-performance program. The Pay for Performance program has about 12 standard measures, and it also has a set of optional measures. Our HCH clinicians were able to lobby this health plan and its decision makers to include measures like chronic pain assessment, depression screening, regular assessment of CD4 count for patients with HIV into this Pay for Performance program. So I wanted to share this because it really gets back to that, who is your leader at your health center and how are they connected to outside quality efforts that can be linked to the work that you're doing inside your health center. We know that our health issues of homeless patients are generally less well reflected in national and standard measures. There was a feasibility study in September of 2010 that was conducted across HCH sites, and no shockers, they found that missing from sort of our standard measure sets were measures that had to do with behavioral health, cognitive impairment, social functioning, reproductive health, medical respite. I would love to hear from people at the end of this presentation if you've developed any standard measures with numerators and denominators that can get at some of these aspects of healthcare. We'd certainly love to translate those here to San Francisco. A couple of remarks about setting goals, and this has to do with your periodic assessments. Are there national benchmarks and standard performance measures that you can use? One helpful tool that has been brought to San Francisco again by our health plan is this concept of calculating relative improvement instead of absolute improvement. So when you're looking at your baseline and how well you've improved or not improved from that baseline, if you Google relative improvement, and often I'm sure many of you are familiar with this concept, but it was new to us as of 3 years ago, and it became a much better way of measuring how well we were improving across core measures, and it's been really embraced by the whole system, and it's how everybody has started to look at their improvement work. For your goals, my experience has been really just choose 2 to 3 measures, no more than 5, for a year's worth of QI work. Anything beyond that is not sustainable. This is from Dr. Seiji Hayashi's presentation on leveraging your QI and QA resources. He just talks about ways to review outcomes, and there's just a little process map to your right that shows one way to think about that. What I'll touch on in the case studies are the use of dashboards, provider report cards, a data wall, and tracking a population of interest. This is part of your regular assessment plan, but what I'm encouraging people to think about is how you can evaluate your outcomes in a way that involves your whole team and presents data for people to look at and respond to. So here's just a quick example. Okay. Here's a quick example of the primary care data wall at the consortium. You might not be able to see the measures up close, so there's about 13 measures on this data wall. The 2 that are circled represent the 2 that are the goals for all the primary care clinics for the year. So it doesn't mean by choosing 2 or 3 measures that you're not looking and measuring anything else. It just means that you're focusing attention on just a few. So let's move into our case studies. We're going to start with the San Francisco Community Clinic Consortium and then move on to the 2 other organizations that you see named here. San Francisco Community Clinic Consortium is a network of federally qualified health centers, community clinics, and lookalike clinics. We'll focus on what the consortium did to build its QI QA plan and how it does periodic assessments. It took about 3 years, so if you're new to quality or you're ready to sort of transform your quality program, keep in mind that this does take time, and don't sell yourself short on an effective timeline for building something that's really sustainable. So in about 3 years, it took time to get really clear about what we wanted to measure. There was a real emphasis on defining roles, so putting together a QI committee, identifying leaders for this QI committee, and this was a QI committee that was going to represent all the partner health centers that belonged to the consortium. Luckily, we have a picture there, but of a great medical director that came on who was a real champion of quality and very effective at building strategic plans and priorities with our board of directors. so that in 2010, the board adopted a strategic plan that supported partner health centers to achieve meaningful use, and that allowed us to begin to adapt our healthcare for homeless quality measure set that we looked at to make sure that those measures could be reported electronically out of a disease registry or an EHR, and we definitely capitalized on the Vista AmeriCorps member to bring in some folks to help us get that going. Here's how we identified our measures, just a little bit about where they came from. So the consortium wanted to pull specifically quality measures that could look at healthcare delivered to homeless adults. And they really used the clinician's general recommendations document, which I'm sure a lot of you have seen. Here were the measures as of 2009. So there were 20 measures. I know that's a lot. This is the core set. In the last 2 years, the UDS clinical quality measures have been added, and that has meant removing other measures. So when you add measures, that gives you an opportunity as you're doing your QI, QA planning to look at what you no longer have the capacity to assess, or maybe what doesn't need to be assessed on a yearly basis. And I'll give you a link at the end to the consortium website so you can find out more about their quality measures. So some challenges and pitfalls and great expectations with this quality audit. You can see that even though we were electronic, there were still sites that wanted to print out and manually capture some of the data. However, this was done in a team environment. Here's just a couple screenshots of the Eye-to-Eye Disease Registry, which I'm sure people are familiar with. This is the registry that we used to conduct what we called the quality audit, where we looked at these quality measures. There's a screenshot to the left, which is where you enter your data, and then the screenshot to the right is the report that we easily customized, and every clinic could run by provider. You could use it as a report card, or by the entire clinic, or by the entire organization. The results from this effort at the consortium were pretty promising. In the majority of cases, people at health centers who were using these measures to look at quality of care in a standard way had teams that they put together. So 80% of members worked with at least 2 or more people at their health center to evaluate these measures. In addition, the majority of people felt that this was an excellent learning opportunity for their clinic, for everybody involved, not just clinicians and not just administrators, to become familiar with what quality measures were. What we were transforming from was having a nurse go in and look at patient charts and write up a report of how well the clinic was doing, to doing quality assessment. All right, so we're going to move on to our next case study, which is the Department of Public Health Community-Oriented Primary Care Program. You can see a few details about this program, and we'll be focusing on how the Department of Public Health meets the focused responsibility core requirement and how they meet the periodic assessment core requirement. This is a bureaucracy. We're part of a large, complex system. So I just want to draw your attention to the QI committee structure. A member from each of the 14 health centers that you saw earlier on the map. There are 2 things that QI committee members are responsible for as being representatives of their health centers. One is to annually report on the success of their QI program and their coming year's QI plan, so they make this report to their peers. And the other is to be responsible for data and outcome reporting. So centrally we develop reports, but in the context of that committee, we're looking at individual health center data trended over time and having discussions about how people are meeting or not meeting goals. I told you that each health center had a representative, and these representatives are people who can do the following. They clarify the aims of the network-wide QI goals that are set, so they do the messaging back at their health centers. They talk about and explain what the measures are and how they're organized to their health centers. They look at results. They provide positive feedback to their QI teams, and they're quite skilled at discussing trends and prognosis and asking their QI colleagues on the committee and back at their individual health centers if things aren't going well, why. What the Department of Public Health really tries to do in terms of cultivating these leaders is make the role of being a PCQI representative an honor. In some cases, there's been negotiations with medical directors to increase the percentage of administrative time that this QI representative will have to do QI work. In other settings, they may rotate members, or the management team selects a member who's going to represent the clinic. And they're often looking for leadership development opportunities or programs to send these members to. So again, it can become a coveted position. Centrally, we have a primary care toolkit that helps to organize the work of this QI committee. Within the toolkit, there are templates that are easily, filled out to describe the core services provided. There's a template to provide goals and the committee structure, so there's a QI plan template that can get updated every year. And then there's a set of tools to do this reporting in a standard way, so using a standard PowerPoint, which is just barely 6 slides, and a 2-page reporting format. The second thing that the Department of Public Health really worked to do was to start to show improvement data. So this was a big effort. It was to publicly display improvement data. Here's an example of where we started. A lot of you probably have this, some kind of board in a staff room that has some data up on it that may or may not get updated frequently. And centrally, what we tried to do was to move towards something more organized and structured and consistent across our network of health centers. And that was the primary care data wall. And you see 2 of our a health worker and a nurse manager standing next to their data wall, proudly smiling. What the data wall shows are 13 measures related to clinic operations, so third next available appointment and no-show rate, clinical outcomes like diabetes control, blood pressure control, LDL control, and then people measures, results from staff and patient experience surveys that are done in a standard way across the network. In 2012, we're working to incorporate measures to bring the data wall into clinics that see high numbers of homeless adults. And we'll start to have discussions about what those measures might be. One thing that we've been thinking about in terms of messaging is, what the research tells us is that homelessness often begins with an illness. So we want to prevent the exacerbation of illnesses and the onset of illnesses like diabetes, hypertension, COPD, and asthma. And because many of the measures that you see there in the pictures are focused on chronic disease management, we want to make the link between how those measures still are applicable to our homeless population, especially if we're able to look at how well our homeless population is able to manage disease compared to our general primary care population. And that gets at one of our core values, which is eliminating health disparities between our homeless patients and our general primary care patients. So our last case study is Tom Waddell Health Center. 2 quotes from the health center that I found valuable in talking to them. We'll talk about how they do ongoing QI and QA planning and how they do focused responsibility. So the other day, one of the clinicians there, when I asked, how do you do QI work and how do you stay so motivated to do it, she said, you have to use your mission to determine how you will do quality work. And one of the questions they ask in their QI committees is, how do we do justice to the things that are unique about our work? Now, this is the health center in the Department of Public Health that has the largest percentage of homeless patients. They have an urgent care setting, community sites. This is where the innovation goes on in terms of serving and delivering high-quality care to patients who are at risk of homelessness or homeless. So on the left, you see some of the measures that this QI committee looks at. And earlier we talked about messaging and focused responsibility. So these are the messages that QI leaders in this health center are promoting when they're introducing these measures and keeping these initiatives going with their workforce. The messages are that our unique PDSAs and interventions are really about outreach and retention efforts. So how are outreach and retention efforts different for our homeless patients than they would be in some of our fellow health centers where people can be reached more easily and are perhaps more easily engaged in primary care? Another message and really technique that this health center has used that might be applicable to your settings is for some of these measures to only focus on patients who have been assigned a primary care provider. So if in your electronic data systems or database, you have some patients who are assigned a primary care provider because they're what you might call active or part of a panel, and some patients who are not because maybe they are not yet engaged or have only been seen once or maybe only being seen for an urgent need. You might want your denominators for some of your quality measures to just include patients who are assigned a primary care provider and are engaged in care. Another message is to really try to, again, make the link between some of the general healthcare maintenance measures that we look at and how these apply to our homeless population. And one of the pieces of advice from the QI leaders at Tom Waddell Health Center is that in general, these blood pressure control, diabetes control measures can help your QI program to develop. So they may not be directly applicable or the most meaningful measures for your clinic, but they will help grow your QI infrastructure, get your team systematized and routinized into doing and delivering care in a way that makes sense for your homeless patients and allow you to move on and to feel more confident for tackling things that are more applicable to your homeless population, such as chronic pain and TB testing. Oh, and once a year, Tom Waddell Health Center does a clinic-wide planning meeting where everybody is invited to choose their QI priorities. Okay, so focused responsibility at Tom Waddell Health Center. The way that this works, here on the left you see who makes up the QI committee at Tom Waddell. And who doesn't. So this is a health center that's probably just like yours where there's a lot of flux in terms of who is involved in the QI work. For this reason, I think this health center has been strategic in making this QI committee purposely multidisciplinary and making sure that there are enough clinicians or people with a clinical background like the MD, nurse manager, and assistant medical director who are serving on this QI committee. In addition, there are some accountability structures in place that I thought were worth noting. As part of that annual planning process, the QI committee meets with the management team to find out what the management team's strategic goals are for that year so that any QI committee initiatives, measures, goals are in line with what the priorities of the management team are. And that really reminds us of what we talked about earlier with making sure that there is some sort of regular structure so that your QI committee representative, director, leader is regularly interfacing with that management team. Another interesting accountability system that Tom Waddell has developed is their performance appraisals for staff assess participation in QI work. So it's expected that all staff are participating in some QI project. And this really makes sure that your front office staff, your clerks, your health workers, your health coaches are all engaged in some kind of team, some kind of project, and that it's expected that their supervisor knows what that project is and assesses the value of their participation on that project. Tom Waddell also actively looks for training opportunities outside its health center to send QI committee members to. So again, if you're on the QI committee, you get to participate in these great training opportunities. They also use their monthly all-staff meeting to incorporate basic QI training concepts, a 30-minute fishbone analysis training, a 45-minute workflow diagram training, how to do a quick PDSA cycle. Those things are brought in so that QI committee members can link back to the work of the larger health center. And coming back to this idea about Tom Waddell and how they message, another great sort of perspective that Tom Waddell has as a case study is thinking about their denominator, right? So homeless patients who may or may not be engaged in care. What Tom Waddell has said is that our denominator does not make us exempt from striving for the highest quality of care for our patients. What we're responsible for understanding is how our patient population is different and how the approaches that we take to improving our quality outcomes are going to be reflective of the uniqueness of that population. So really what Tom Waddell has emphasized is the QI strategies that we take on and that we adopt are different. They have to do with how to engage patients, get them into care, help ameliorate some of the other things that are going on in their lives so that they can manage some of the chronic conditions that they have. So this clinic is very thoughtful about what kinds of QI strategies it takes on. And here's an example of data that get collected about where patients live. So these data might look very simple. Okay, you know, patients kind of live in all sorts of settings, shelters, SRO hotels with friends and family. There's a sizable number of patients where living situation is not documented. But what do these data tell us about how we need to outreach to and engage these patients? Do we need to think about inviting friends and family or a supportive friend to some of the group visits that our patients are participating in? If we know that friends and family are a source of home or part of the home environment of our homeless patients, the social support work required for staying healthy, looking at the shelter system and thinking about where we can find our patients who may not be engaged in care, where can we send our health workers and our outreach workers, and then looking at some of the SRO hotels or single-room occupancy hotels where our patients live and what the social structures are there and how maybe we can do group visits there and do some kind of outreach or intervention related to our QI work in those settings. So I just want to summarize the case studies that we talked through. It may have been too fast, but the picture you see here is boxes of cookies that the San Francisco Community Clinic Consortium put together and took out to all of the healthcare for homeless sites that conducted this review of quality using these standard measures that I talked about first. So rewarding our participants in quality and doing something nice, relatively easy for our participants so that QI teams are recognized for their work. So just thoughts about improvement efforts. A few things to think about. I'm going to try not to read these out loud because I think everyone can probably read what's going on here. If you have your own ideas or practices to share about other ways to incorporate these QI program requirements into existing work, that would be helpful as well. And thank you everyone for listening, and look forward to answering your questions.
The first question asks, what does your group use as a standard tool for patient satisfaction? And it goes on, how have you thought about what tool to use in the HCH clinics?
Sure. It's a great question. There's not really a lot of specific HCH-focused tools. I think it would be a great initiative for the council to explore. What we've used in the past at both the consortium and the Department of Public Health is the, my sense is it's a little outdated at this point, no offense to the Bureau for Primary Health Care, but there is a patient satisfaction tool on the Bureau of Primary Health Care website. It's not hard to find by simply Googling patient satisfaction, BIPIC, and you can look at that tool. The tool is great for a couple reasons. One is it's low literacy and it's quite simple to fill out. The tool is not so great in that it doesn't really get at some of the unique circumstances of homeless patients. In the Department of Public Health, we partnered again by keeping abreast of QI initiatives going on outside our safety net. We were able to leverage some support to use the CAPS survey, consumer assessment, hospitals, something, the acronym title isn't quite coming to me, but I'm sure somebody else knows exactly what it stands for. It's CAHPS. And the CAPS tool really gets at some aspects of patient-centered medical home requirements, which is a pro for using it. We have had some concerns among some of our HCH clinicians about how useful the survey will be for homeless patients because it does require, there's some logic involved. But I've listened to a couple conference calls about the pilot testing of the new CAPS tool, and it seems to work in a variety of settings. I think it's about a 5th grade reading level, so probably not so different from the local newspaper that many patients read online or in print. So I think the CAPS survey is the right way to go from an administrative perspective because it helps you meet some of the PCMH requirements. If you have a tool that you're using that's really effective inside your clinic, I think that's great too, and that's worth sharing. If there's a follow-up question to that, I could go on and on. But
thank you, Amy. So the next question comes from Melissa, and she asks, do you have any suggestions for engaging the fiscal team in QI plans?
That's a great question. We found that members of our fiscal team are most interested in measures having to do with ER utilization and also operations. So the fiscal team is interested in measures having to do with cycle time, right? So if your cycle time from the moment a patient enters the clinic to when they leave is very long, that may mean that there are other patients who can't be seen. That seems to be, those operational measures have been effective in my experience in these 3 settings at engaging members of the fiscal team. So cycle time, time to third next available appointment, and no-show rate. We evaluated, I showed you that data wall earlier, and we had done a survey across our 7 health centers who were using the data wall at the time, and we surveyed everybody in the health center, so people who were involved in fiscal operations, clinical care, behavioral care, and asked them to rate, which measures are most important to you, and we found overwhelmingly that operations and fiscal-oriented staff were most interested in population demographics, so who they were serving, and those operational measures that I talked about.
Great, thank you. The last question is just asking if the primary care toolkit is available to everyone on the call.
We can, Julie, if we pass it on to you in PDF form, can it be posted somewhere? I don't know if that's possible.
We can post that on our website with the recording of the webinar, and also we can send it in the link. We send a link to all the people who've registered for the webinar, so even if they weren't able to attend, we'll send them a link to not only the evaluation survey and a recording of the webinar, but we can also send the toolkit too. Yeah,
the toolkit is great, and I would also recommend contacting the San Francisco Community Clinic Consortium. I think Julie and Patrina will show the links at the end of this call, but the consortium has a great, not that everybody wants to measure 20 aspects of homeless care, but if you want to use some of them, they have what's called their Quality Audit Guide, and it gives really in-depth details of numerators, denominators, exclusion criteria for taking the HCH Clinicians Council general guidelines for healthcare, transforming those into measurable outcomes. I would recommend taking a look at that if you're looking for some unique measures that can help you evaluate your homeless care.
Great. And that will conclude our Q&A session. And so I just would like to turn your attention now to our resources slide. Here's a nice listing of links that Amy mentioned during her presentation. And again, a PDF of this PowerPoint will be posted on our website at www.nhchc.org within 3 business days, and then you'll also receive a link to that once it's posted. Thank you for joining the Laying the Groundwork for Meeting QI/QA Program Expectations in an HCH Setting webinar, produced by the National Healthcare for the Homeless Council. Please visit the NHCHC website for a listing of upcoming council webinars and other educational products. This meeting will now be closed.